Ladies and gentlemen, good afternoon, and we'll call the meeting of the Rutherford County Benefits and Insurance Committee to order. And you have received a copy of the minutes of the last meeting. We need a motion to approve those. Ms. Boney, and we have a second. Ms. Hickerson, did anyone have any corrections or additions? Okay, if not, all of you in favor of that, then please say aye. Aye. Any opposed? Thank you very much. All right, next we're going to have some discussion regarding our financial condition. Mrs. Stinson.
You refer to Fund 264, we'll start there. For the month of December, our per employee per month cost is $838.70 compared to prior year same time of $741.06. Our year-to-date average is $863.81 compared to prior year-to-date of $825.91. When we combine our clinic experience, our per employee per month increases to $873.56 compared to prior year of $769.86. Our year-to-date average is $896.79 with year-to-date average of $855.94 for prior year, demonstrating a trend of 4.8% over prior year.
Okay, that's the report, financial report. We'll have some more discussion after this, but we need a motion to approve her report.
She said no motion.
No motion is necessary, Ms. Anderson? Okay. All right, well, that's good. So you have received the report that she has given. Now, Mrs. Stinson, she wants to continue this discussion and give you a bigger base of information. All right.
There is additional information included with Fund 264's reporting. If you will refer to the first page of this document, the top says Rutherford County Premium Needs All Actives 2012. I'd like to provide you with a calendar year financial picture for 2012 to help prepare you for upcoming discussions in the month of March and April when we begin to discuss premiums for 2014. The first sheet you have in front of you was presented to you in March of 2011. And what this shows is, based on the actuarial review of our plan, what the projected premiums were needed for 2012. Now, mind you, because our fiscal year is 7/1 and everything else functions on a calendar year, we have to begin the process of setting rates about 6 months ahead of the industry standard for rate determination. Because of that, we will actually use experience to help set rates. As an example, it would run from November of 2010 through January 2011 for this particular period of setting rates for 2000 and the following year. If you'll look at the sheet in front of you, what it shows is that when we looked at this, our premium needs at that time were projected to be $48,285,451. $48,285,451. We voted to not pass an increase along in 2012. What that resulted in, the expected premium level, was $46,667,119. In essence, what we do when we don't pass along the recommended increase, the necessary increase levels, is we go on risk. We say that we understand what the projected premium needs are, but we believe our experience shows us that we are going to have a year good enough to absorb the claims that we will incur in that year. There are other factors that increase our costs throughout a year. One of those would be the number of enrollments that we have. In speaking with Ms. Barnes, I think you said we add roughly 100 new employees a year, thereabouts. That would increase our costs. When we go through open enrollment for January of the following year, what plan elections are made and what tier people enroll in also impact our costs. Where we ended up in 2012, if you'll look at the next sheet, in 2012, our revenues, our actual revenues for 2012 was $48,518,479. Our claims experience for 2012 was $52,367,177. We had a deficit of $3.8 million that came out of reserves in order to actually fund our claims for 2012. That's going to happen. There's not a crystal ball that we look at that we can always know verbatim how the claims are going to run and that we can set dollar for dollar. Historically, we've done really well, but there will be years like this where you have some claims in there for various reasons that will impact your final spend rate. Going forward, how aggressive we are in setting rate increases is going to be important, and I'm going to tell you why. Beginning in 2014, currently we're in the process of developing the rates for 2014. In addition to the 1% contribution reduction that was passed not long ago, meaning that the county will reduce their contribution towards employee premiums by 1%, there are going to be also impacts to health care reform. Now, using the information that I just showed you, our actual premiums that we gained was around $48.5 million. So that right there is about $485,000, a 1% reduction would demonstrate to our employees, okay? In addition, you have health care reform in 2014 that's going to have a significant impact on us. There are things such as pre-existing, no longer exist both for children or adults. Dependents to age 26, we've already incurred some of those expenses, but there will be additional expenses for those children who are aging up or who are no longer full-time students that will have an impact to us. Auto enrollment begins in 2014. Right now, if an employee doesn't want to participate in our insurance, they don't have to do anything. We don't worry about those folks. Under healthcare reform, we have to worry about them. They either have to go in and decline our insurance, or we will automatically enroll them in a plan. So we have that cost that will be associated with us. And part-time seasonal employees that may not currently be benefit eligible may become benefit eligible because of healthcare reform. If they are averaging 30 hours a week over a period of time that we deem as our period for review, then they qualify for benefits. When we did the Deloitte review for healthcare reform, just the part-time seasonal employees were expected to be $279,000 to the plan starting next year. There's also a research fee that the county will have to pay that is a $1 per member per year. That's per belly buttons. We have over 12,000 people on our plan currently, so there's $12,000 we'll have to pay next year. In addition, there is what's called a transitional reinsurance fee, which is a fee that we will pay to the government, and that particular fee will run anywhere between $63 to $90 per member per year, so that's per belly button. That one provision alone will cost the county insurance plan between $600,000 to $1.1 million. So combined, based on the expected experience under healthcare reform, we're looking at a little over $2 million in impact because of healthcare reform next year. So we will have some difficult decisions in our discussions for 2014. We have to decide, are we going to replenish those reserves that we just lost? How are we going to continue to reduce the county contribution as we've already passed, which is that 1%? How are we going to absorb the health care reform cost? Cowan Benefits is assisting us with our health care review for health care reform. And they are going to work closely with myself and with Cigna, who helps do the actuarial study as we set premiums to ensure that all the healthcare reform costs are set properly inside of our premium proposals. We will have to look at things like plan design. How do we structure our various tiers? Do we need to start charging more for spouses that are on the plan? Those are going to be some of the decisions that we will have to make, and we're going to have to make those decisions fairly quickly in time for budget season. So I wanted to provide you with this information today so that you can begin to wrap your head around what's in front of us, so that when we do have the actual analysis that's completed for 2014, you'll be better prepared for those discussions.
Okay, I'm sure most of you are sort of stunned and taken back by all of this discussion. So do you have any questions? Or it's a lot to think about, a lot of dollars and most of those dollars she defined that are going to be required for us to pay for this new health care, we don't get anything in return. It's just an assessment, a tax against us to send to the federal government for all practical purposes, especially that last one that she said it could be 700,000 to $1.2 million or something. So all that being said, these meetings won't be so much fun as they might have been in the past, because we're going to have some really difficult discussion. Did anybody pick up on anything they want a little bit more information on at this moment? Anything else you want to tell them, Mrs. Stinson?
No, sir, I don't believe so.
Okay.
We have Fund 266.
Well, that's just a heads up on, when do you think, are you going to just sort of have a continuing update on this each month as we go forward now?
Typically, what happens is we have to have the experience through the month of January in order to begin actually setting the rates, because that's part of our review period for claims and trend. So the earliest that I would be able to come back and present information to you would be March. That's typically whenever we do that. And at that point, we can look at it, make recommendations on how we feel like the plans may need to be revised, some cost savings techniques that we could implement, and those types of discussions.
Now, these things that we have to do with respect to healthcare reform, you said 2014, is that January of 2014 when we have to start making those payments?
I don't know what the actual payment period would be. So to say, will we have to pay the reinsurance fee on January 1? I'm not aware. I'm not sure yet.
So we'll have to take into account what part of our fiscal year that we're addressing all of these issues. Okay. Okay, anyone else want to join in this discussion right now, or we'll wait till March, basically? All right. Next, I believe you have some information regarding our workers' comps, basically our OJI.
So we have Fund 266 as well in front of you if you'd like to open that report.
Okay. Give them an update on that then.
Yes, sir. For Fund 66 at the end of December, our year-to-date was $431,374 compared to prior year of $358,269 for a 20% increase over prior year. And Mr. Good will be able to provide you details on what our actual experience was in terms of types of claims for December.
Okay, and we're about to wind down with the workers' comp claims, I suppose, but there's still a few out there.
We do. I think we have 19 still open on our books. Some will remain indefinitely. But we do continue to see every once in a while one here and there come off of our claims.
Okay. Right, let's see. Ms. Perry, and you're going to give us a wellness update then?
Mr. Good is actually next for workers' comp.
Oh, you didn't do that for him.
No, his is a different report.
Okay, Mr. Good. A different report, but a related report.
Good afternoon. As the report you look in front of you, I would like to report for two things. First part being the month of December of 2012, and then give you a calendar year review after that. In the month of December, you'll notice that we had a total of 12 injuries requiring medical attention. You see the breakout there, bringing the year total to 208. Of those 208, 151 of them were OSHA recordable. 70 of those injuries required restrictive days, and 25 had lost time days. On the next page, you'll see the graph that will compare the this past year with the two previous years. Just to note there, the graph's kind of hard to read as far as totals, but in 2010, we had 210 total injuries requiring medical attention. In 2011, we had 237. And in 2012, we were back down to 208. So just to give you a reflection of that. In the month of December, the total dollars incurred for those 12 injuries were $12,250. The Board of Education had 7 of them for a total incurred dollars of $5,950. The county general had 4 for $5,350. As you look at the county, it's a breakdown on the county. Of those 4, you'll notice that where they occurred at in the PAWS or Animal Services, Emergency Management, and I make note that that Emergency Management is actually the Volunteer Fire Department. EMA did not have any. That one was in the Volunteer Fire Department, and the Juvenile Detention. And to round out the 12 for the month of December was the Highway Department. You'll notice they had that one for $950. For the year to date, or for the year total for 2012, we had the total of 208 claims. Total dollars incurred for the year was $541,801.45. Of that 208, 124 of them were with the Board of Education. Total dollars incurred there was $302,416.72. The county general had 80 for $223,337.63. Again, breaking out the county, 80 there you'll see on the next page where they were in the county general. And then last page there you'll notice that the Highway Department had a total of 4 for last year. And their total were $16,047.10. The last thing that you'll have there in your packet, you'll notice is the OSHA Form 300A. We're required by OSHA to post this in all the county buildings. It has to be posted from February the 1st to the April 30th. And you'll see that it's presented here with a summary of all that. It has the total average number of employees. The county averaged last year 5,960 employees. And total hours worked for the county was 9,661,766 hours for all the county employees. And I presented a copy of this to the county's Employee Safety Committee to post. We'll be sending it out by email to all those also to make sure, but I provide you a copy. If you look in your office building and you do not have a copy posted, if you would, please post that between February the 1st and April the 30th. If you don't have one posted in your office area. Are there any questions?
Mr. Good, what's your assessment? How did we do?
Well, obviously we're down as far as the injuries are concerned because we're actually 2 less than we were 2 years ago, but the dollars are up. It's showing that either there's a little bit more severity or the cost of the individual claims are going up. So the cost of treatment over the last 2 years has gone up. So.
Okay, anyone else have a question? All right, then, thank you very much. Now, Miss Kelly Perry, and we're ready for her.
Good afternoon. I'd like to give you the wellness report for December 2012. For our Wellness on Wheels, we went to the Rutherford County Board of Ed Maintenance Department on the 14th of December. And we screened 38% of the eligible population there in that department. 47% of them had greater blood pressure than 140/90. 94% of them had elevated BMI, and 65% had elevated body fat. And Cigna screened 17 people for Dermascan. Everyone with abnormal results was referred to the MedPoint Clinic for additional testing. We had 11 active cases with individual wellness coaches Lori Cook through Take Care. 6 of those cases are new. And for our upcoming activities, we are starting our HRA biometric screening February 5th through March 28th. And we have iPad 2 to give away as incentive. We're going to do a drawing of anybody that participates in their biometrics and HRA during those dates get entered into the drawing. And we are going to, the first month, go into the clinics, Walter Hill, Blackman, and Stewart's Creek. And then the next month, we are going to go out to certain departments like the sheriff's office, highway, and possibly some schools. For February 5th through March 12th, we are starting a manager weight program at Blackman Clinic at 5:30 to 6:30. There are free foot screenings at Nahas Foot and Ankle through Fleet Feet on February 6th. February 19th, the Life Services webinar is Keeping Love Alive from 11 and 1 o'clock, and a CPR certification class for county employees only for $5 as at the EMA training, February 28th, 5:30 to 9. Any information that you would like in addition to that, the flyers for each of these activities is listed on the website below. Anybody have any questions? Thank you.
Yes, Ms. Perry, and I have a question. I'm sure, how many of these screenings do we have, or are we offering? Is this, you just mentioned one particular department, but have all of the other departments had opportunities for those screenings, et cetera, and what's the plan?
Lori Cook is the wellness specialist with Take Care, and she and I are scheduling events at different departments. So this summer, we actually focused on county general departments since the schools were not in session. And we went to most of the county general departments. We've gone to a few schools, and we're just kind of trying to make our way down the list to make it available for everybody.
Okay, and Ms. Stinson just started us off with a report on how much our costs are increasing on health care. And what this is all about is preventative, I believe. So it seems like we have an opportunity here, if we can really continue this process, to engage our employees and help them. So we got to encourage that somehow. Ms. Stinson, you want to say something?
I was just going to say that historically, we've really struggled on the wellness front with participation. It is a challenge trying to find the right programs offered at the right times to engage employees, especially since typically in wellness programs there are incentives involved, and that's what typically motivates people to participate. It's either a gift card or something like that. We don't do that, so that makes it even more challenging. What we are finding, though, is that this Wellness on Wheels program is one of the best received programs that we've ever rolled out, and those who do participate, not only are we finding, as clearly demonstrated in the results today, some things that need to be addressed, but the employees routinely, after one of these Wellness on Wheels, will get some type of email, Ms. Perrin will, that talks about how thankful they were that they had gone out and were at their school or they were in their department, and there is an appreciation level. So what we hope to see as we circle back around to some of these departments is greater participation, and that's really going to come from the leaders of that department to make the time available for their employees to go, because you are going during normal business hours. Isn't that correct, Ms. Perrin?
That is correct, and we invested last year some of our budget in a Colestech machine. We have the ability to do a screening that's a non-fasting screening, and you can get your results in 7 to 10 minutes. So it does make a difference to be able to give your glucose, total cholesterol, blood sugar, you got your blood pressure, and these numbers that you can give to one of the employees within 10 minutes. So you don't have to come in, make another appointment to get these numbers.
What's the typical cost for an employee that we incur to actually conduct this screening?
It's about $10 a person per screening, and this cost last year came out of the wellness budget given to us through Cigna.
Okay, it's money well spent and time well spent, so we have to encourage all of us to participate more in that if we possibly can. Any other questions? All right, thank you.
Thanks.
Now we are ready for a life AD&D discussion about an upcoming bid, I believe.
Yes, sir, that's correct. Currently, we are in the process of finalizing our bid for our property and casualty insurance that we hope to release sometime in the March to April timeframe. In addition, this year, we also have our life and AD&D insurance that we need to put to bid, and that would be a bid that would happen probably along the same timeframe with I believe the date is a 7/1 effective date on that. So what I'm asking today is just approval to actually put those lines of business out to bid.
And it's just for the life and the AD&D?
Yes, sir.
Okay. we need a motion to allow her to submit requests for bids. Okay, Ms. Ely, and and Ms. Harvey. All right, any discussion or questions? So that will happen sometime a month or two or three before July the 1st.
Yes, sir, that's correct.
Any other discussion? Okay, all of you in favor of that, please say aye. Any opposed? All right, thank you. Now, Cigna Annual Report.
We'll have Mr. Huffman from Cigna come up and join us today. Annually, Cigna provides me with an experience report, and the current report that Mr. Huffman will be covering is for the experience of July 2011 through June of 2012. And so, Mr. Huffman, if you'd like to walk through those reports.
In your package, you have about a 6-page document. Looks like this. The good news is it's only 6 pages. Every year, I bring out about 4 people. We meet with Ms. Stinson for about 3 hours and go through a pretty significant presentation for medical, pharmacy, and dental utilization. And what it is basically just to go through all the utilization, looking at what's driving the plan, and really it's a year-over-year comparison. So we not only see what's happening now, but how does it compare to how it ran last year. So what I've done is tried to pull some summary exhibits from those 3 presentations to put here to give you an idea of what we're looking at. If you'll look on the very front page, some characteristics to just keep in mind as I walk through this. Keep in mind this is just Cigna claim experience for the medical, pharmacy, and dental. So none of the MedPoint Clinic costs are going to be associated with this. It's not in this presentation. And then the other thing is, as Melissa mentioned, we're reviewing your fiscal policy years. We do this late in the year. We meet with her in the 4th quarter, and we look at the period 7/1 to 7/1, and that was 2010 to 2011, and then 7/1 2011 to 7/1 2012. So where you see the term base period, that's last year, and where you see the term current period, that's going to be the current year. Okay. Looking at page 2. Again, this is a quick medical-only, Cigna-only snapshot of the characteristics of your plan last year versus this year. And you'll notice right in the middle at the top, we're looking at a membership summary. You can see you had a little bit of growth in the number of employees that were on the medical plan. And underneath that, you can see the average number of members in the plan grew as well. Now, members is just as Ms. Stinson put it, the number of belly buttons on the plan. Now, one thing to note that's not on this page is you have almost as many dependents as you do employees. And what's significant about that is that the spouses typically, and in your case is true, the spouses incur almost nearly the exact same amount of medical cost as your employees do on a per head basis. So you are literally paying the same, in some cases more, for the spouses than the employees. And some people just need to be reminded of that your employees who you value the most, you're treating their spouses just as well. So moving down the page, what do you pay Cigna to do? We administer your claims. We're doing everything we can to try to lower the cost through various things through our claim administration. The analysis of charges and payments, as you can see down the page, submitted charges. This year we received close to $95 million in medical submitted charges from doctors' hospitals. From that number, we find claims that are duplicates. We remove our discounts based on our contracts. We apply deductibles and coinsurance and copays so that we pull out the member portion. We coordinate with other carriers if there are any to get that number down to the bottom red number of $32,460,000. So that is the difference between what is submitted to Cigna versus what you as a county are actually paying. Okay, and you can see the difference there from last year or from the base period to the current period was about a 9% increase in total dollars. Part of that number is due to the increase in the number of people that you're covering. Looking over at the top of the right side of the page, we want to break down your cost into what we call a per member per year basis or a per employee per year basis. That's what those abbreviations stand for. And then we also look at that average on a per member basis with and without large catastrophic claims. And I'll talk a little bit more about what we refer to as a catastrophic claim. It's anything that's over $100,000 on one person. And the main thing to note here that I've highlighted in red is that when you include all your claims together, you're seeing about a 4.5% medical cost increase year over year. And that's consistent with what Melissa just told you regarding the year over year trending that she's seeing. However, if you remove the individuals, the handful of people who have really high claims, those that are over $100,000, and you just take them out of the equation, your trend is really actually running about 8.4% year over year. Now, that's not a huge concern because literally that is what we expect to see every year from all of our clients. We tell our clients, you can expect, and it's normal, to see about an 8 to 9% medical increase in trend if nothing changes. If you had the same people on the plan and they all got the same care that they got last year, their costs would be about 8% higher the next year just due to medical inflation and things of that nature. So that's what is built in typically when we look at rates for the next year is we have to understand that not only are your plans changing, your people changing, but the cost of everything is going up exponentially, a lot more than typical inflation or consumer price index. The last thing on this page that I'll point out is also highlighted in red. The emergency room visits per 1,000 members. So we want to get an apples-to-apples comparison. We did notice and commented about the fact that we saw a slight increase in emergency room visits, close to a 12.5% increase in number of visits. And that's pretty significant. The emergency room is probably the most expensive venue to use, and we do a lot of studies at Cigna to determine if there are other or better venues for people's treatments. You know, we look to see when are visits done? Were they after hours on the weekends? Were they for ear, nose, and throat? Were they truly life-threatening, life and limb-threatening, and things of that nature? And are they things that we could steer people to urgent care clinics, convenience care clinics, on-site clinics, things of that nature, possibly? So we're working with Ms. Stinson on that. One of the things she said we're going to do is try to get more communication out to use the on-site clinics for that. Not to mention the new copay plan that was just put in place in 2013 has a copay for the emergency room visit that will be enacted every time someone visits the emergency room.
Can I interject for just a second, Mr. Huff, before you move on? There's a couple of things I'd like to point to. SHRM did a study that was released in March of 2012, and it had actually showed that employers were expected to see an increase of 8.5% during 2012, and that's exactly what Mr. Huffman has demonstrated. So we were average as far as an employer goes for the increase that he's referenced here. The other thing is the ER visits. As he just said, on the copay plan, there is an automatic $150. You walk in the emergency room, it costs you $150. There was one more sheet attached to the premium conversation that we had, which was the tracking history year over year for our enrollment. And you'll see there that our employees actually went to the copay plan. We had 1,222 employees move off of other plans onto our copay plan. That was, just to give you a breakdown for 2013, we have 2,329 that will be in our deductible plan, 1,188 elected the HRA, and then 1,222 elected the copay. So we had a very good response to that plan. So there is some cost containment for emergency room built into that plan. The other thing that we're doing first quarter, because as he talked about where else can people get care other than emergency room, if you recalled when we talked about expanding into the retail market with our clinics, there was 35% of our visits that were steerable visits, meaning that for the analysis that Cigna did, 35% of all the visits that ended up in the emergency room could have gone to an urgent care or a take care retail to be seen. So we will be heavily educating employees about this option once we roll it out to try to steer some of these people back into a more appropriate level of care. So hopefully we'll see a reduction in ER based on a couple of things that we've done recently.
Okay, looking at page 3, as I mentioned, one of the key features that drives a lot of cost are those claimants that exceed $100,000 in total cost during a policy year. Looking at the past 2 years, one thing that did improve was that you had a reduction in the number of large claimants over $100,000, and we look at that on a per 1,000 basis so that it's comparable. But you see that in the base year, we had about 2.5 people per 1,000 hit that threshold, and then during the current year it was 1.9. The other thing to note is that not only did you have a reduction in the number of large claimants, but the total cost per large claimant also decreased as well. We do know, because we analyzed the whole plan, I mean, there was a very significant large claim in the previous year, close to $1.6 million, that is an anomaly. It's considered catastrophic in all senses of the word. That one will skew the prior year and has helped the current year by not being there. So in the red comments, just gives you an idea of what those percentages mean. So the spend that you spent on those high dollar claimants actually decreased 49%, and the claimants per 1,000 decreased 23%. And you actually are now below what we would see as the normative for public sector clients. So you go from a really bad year to a really good year, you're probably going to assume somewhere in between going forward. Okay. The average cost, like I said, was another good feature, was that the average cost decreased close to 36%. Okay, page 4, again, just as a reminder, this is Cigna Pharmacy. So we look at the prescription drug cost that goes through the plan, and this is going to be for the current year, July 2011 through June 2012. We processed in total gross drug costs, so the amount of total drug claims that came through represented about $21,510,000. Of that number, our negotiated savings through the pharmacies and manufacturers represented close to $10 million in savings. Through the efforts of the county and the risk management office and some of the efforts with Cigna and our communications, the generic prescription rate of fill did increase, and that represented close to $1 million in savings just from people choosing generics over brand name equivalents. We had clinical program savings estimated at about $250,000. That would be things like the proton pump inhibitor edits, your Nexiums, Prilosec. That drug requires people to take a generic before they move to a brand, and that in itself, along with other programs such as a narcotics therapy program where we are monitoring individuals who are filling narcotics at multiple docs and multiple pharmacies, and similarly for psychiatric medications so that doctors are aware of what their patients are receiving through other sources. One thing to note, the last two comments, is we're going to start seeing a larger increase in specialty medication ingredient cost, and we did see a significant trend in that cost. Specialty meds are your high-cost meds that are usually $500 or more per script. They're typically biomeds or made from proteins. They're usually injectables, things of that nature, and they're also typically drugs that people really need. You don't want them to avoid them. because they're life-sustaining in many senses. We did see that through our contracts with pharmacies and through the physicians who administer those drugs, we had about $500,000 in contracted savings from specialty meds.
Two of the things that I can think that you all voted on as a group that have resulted in some of the savings here is, one, as he referenced, the narcotic review, so that we can stop the abuse of that process, which is a savings to the plan. The other thing is the preventative generics being at zero cost to employees. That would have contributed to the driving factor of seeing an increase in generics, which is good for them because they're being more medicine compliant, and it's good for us because we realize those savings whenever they switch off of other brands onto a generic medication.
Yeah, that's a good point. That was implemented a year ago. Was it January of 2012? Yeah. So that would be in this data for half a year. Okay. So that would definitely contribute. And in fact, if you turn to page 5, that's the one trend number that I've highlighted in the middle. As you can see, the generic RX utilization rate increased from 72% to almost 76%, which was a 3.6% increase in generic utilization. We say that, as a rule of thumb, every 1% of generic drug spend that you can increase, you're saving close to 1% of pharmacy cost, which can be enormous. We already mentioned that the specialty trend was high. This is something that Cigna, as a national initiative, is looking at to make sure that we can contain this cost, because, again, it's drugs that we need, we want to be out there, but we've got to make sure that that cost does not overtake all the good that you're doing on everything else. So overall, pharmacy trend, that's the top number in red, year over year was approximately 4.1% ingredient cost over last year. So the drugs that your individuals are filling as a whole, on average, is about 4.1% higher than they were last year.
Mr. Huffman,
Yes.
is it not true that in 2014 there are quite a few medications that are slotted to have generic equivalents come out?
Actually, there's a lot starting in 2013 as well, and 2014. We provide her a list, I did not bring it here, of many drugs that are expected to come off patent, which means that then the manufacturers can start creating the generic equivalent for those. And anytime we know of a drug that is scheduled to come off, we automatically put that brand on our preferred category. So even though temporarily that might be an expensive drug, we want that individual to start getting used to taking it, because as soon as a generic is available, that will be filled, and they'll already be accustomed to that drug and used to it, and then see the benefit of going to a generic. But yeah, the list is pretty long, and there's some of the most utilized medications that we'll see. But as I said before, a lot of the things good happening in the pharmaceutical industry almost gets washed away by the advancements in specialty meds because they're so expensive and can do so much good.
You all send out mailers to employees' homes or whomever's on the medication that goes on to generic, is that correct?
Correct.
Okay.
Yeah, and especially anytime someone fills a medication, when there's a generic equivalent available, we'll communicate that to them as well. Okay, last page, page 6. Dental doesn't always get the attention it deserves, but we do provide a brief overview of the dental utilization. It's not as much spend of your money. We did have in the current year about $3,800,000 in charges. What I've pointed out at the bottom is that on an annual basis, year over year, per employee average cost, your dental trend actually decreased. There's a couple of good stories there. So you saw a decrease of about 6.5% in trend. Part of that is due to an increase in our provider network. So as we gain more contracts in our dental network, individuals start to use those in-network doctors, regardless of which dental plan they've chosen, then we'll start to see more discounts through those contracts. And in fact, our net discount did increase from 21% and at 21.5 to 22.5. And that's even higher than what we would expect the normative to be for dental. And in addition, the next bullet point under the comments is that that network utilization increased just slightly as well. One good thing is that we have more people utilizing the plan. We saw an increase in utilization of individuals just having a dental claim go from 59.8 to 60.7. That just means maybe 1% more received a cleaning. So the more people that receive their annual checkup and their cleanings, the more utilization we'll see, but we will see the cost go down because those class 2 and class 3 periodontal disease and major dental benefit costs go away the more preventive that we get. So there's a good story with that. Again, it's not a lot of dollars, but we wanted to point out that we're doing things to mitigate expenses in every situation.
And the dental, we often think that the cleanings is merely just cosmetic and that, we want to all have a pretty smile, but it really is kind of a window to what's going on internally inside of our body. So those cleanings are very important. So anytime that we see that increase, that's a positive.
Questions?
Thank you, Mr. Hoppin. That was a very good report. Now, Melissa, you want to talk about dental benefits?
I do. Kind of continuing on the tail end of Mr. Huffman's report, and actually I didn't realize that, but it was a good segue whenever we developed this agenda. Part of our review, we always talk about things that we could be doing differently, should be doing differently on our plan, and one of the things that has come up recently and what I'm bringing to you for consideration today is the fillings that employees get. Currently, when an employee goes and gets a filling at the dentist, the only thing that we will actually cover through the insurance is the silver filling if it's on the posterior teeth, so your molars, things of that area. The problem is a lot of dentists have moved away from silver fillings and they only do the composite fillings. It's my recommendation that we revise our plan to allow composite fillings on posterior teeth. That's going to cost us roughly $42,000 a year in claims expense to make that change. But I think that we are unduly putting our employees in a difficult situation because once they're there, they don't really have the option of what they get if the dentist doesn't do silver fillings any longer. And most people probably don't understand it until after the fact that we only pay as much as what a silver filling would have cost, even if your dentist just does the composite. So I think we really need to sync that up. We are trending well in dental, so I think that we have the ability to make that change. And I would recommend that we make that change retroactive to January 1st of 2013.
Okay, you hear her recommendation, so we need a motion to that effect if you so desire. All right, Ms. Grace, does anyone make a second? Ms. Hickerson, any discussion or questions? I think that's pretty obvious, right? Now, if you go to the chair, you don't know what they're going to put in your mouth, really. But anyway, I think that's a good catch, and that would be a benefit to our employees. Any other questions? If not, all of you in favor of that, please say aye. Aye. Any opposed? Thank you very much. And Ms. Stinson, I notice in recent days you continue to send out an all-users request for people that have dependents that haven't provided information. The date of expiration on that time is about upon us, isn't it?
Yes, sir, it is. And I've actually, at the last email that went out, it went to all the department heads to identify their people who still have outstanding information. Department heads have been very, very proactive in this process, and I appreciate their participation in reaching out to their employees and saying, hey, you owe something to risk management. So that's been a very effective tool, and we are getting a lot of response, so I appreciate that.
That's good. Okay, so the last count, it was a little over 200 people still had not complied.
Correct.
All right, does anyone else have any other business they want to discuss? Ms. Hickerson and Ms. All right, Ms. Hickerson first.
Where are we at on going into the Walgreens retail on our walk-in clinics?
It looks like that we'll be able to actually, this is transitioning into the clinics, the retail clinics. It looks like by the end of February, we should be able to have that process in place. We are finalizing marketing materials right now, kind of dotting our I's and crossing our T's. And then the thought is, because having dealt with the population, giving them information too far in advance isn't effective. So as soon as it's a green light and we know we're going to hit the date, you will start to see pieces of information go out. And we're going to continue to heavily push that process to try to drive some costs out of our plan.
Okay, Ms. Barnes, that was your question. That's good. Anyone else have a question or any comment? If not, then we are adjourned. Thank you very much.